Radio CAHS, presented by CAHS Chief Executive Dr. Aresh Anwar.
Welcome to Radio CAHS.
Welcome everyone. I think this is our third show. I actually want to thank Monica. I don't want to thank Monica CAHS. I will do in a second. I want to thank DJ Houston, who actually last night hosted Monica CAHS, helping us guide us through the show. And I want to ensure that I don't really forget the enormous amount of effort that Radio Lollipop put in, both each and every day, into keeping our children and families entertained, but also helping support this show. So thank you, DJ Houston, for joining us today. Before I get going, I want to acknowledge the traditional owners, the Warwick people of the proud Noongar Nation, and pay my respects to elders past, present and emerging. And I think that's a theme we're going to really focus on a little later in the show. We're lucky to have Frank Walsh from the Aboriginal Mental Health Service joining us today, and I think he's going to bring some really important reflections on how we're doing in that area. But first, I just want to give some background information, just as by way of where we sit in WA and also within CAHS. So these statistics come as of midnight on Wednesday, the 17th of June, and we know that nationally there have been 7,391 confirmed cases. In WA, as of midnight, the 17th of June, there had been 603 confirmed cases with 592 patients who'd recovered from the disease, and you know, sadly, 9 people have passed away as a consequence. There were 2 active cases remaining in hotel quarantine. And I suppose the question is, when we read out these statistics, the question is, what does it mean for us? And for us, I think the issue is making sure that we don't become complacent. So we are currently refining our CAHS outbreak management program, and many of the leaders in the organisation are going to just be getting a reminder just to go over their current preparedness scenarios, and in fact scenario testing is something again that we're rolling out. The second thing is we have a recovery process that we're planning in parallel to ensuring that we have clear outbreak management program, and that's to ensure that that we don't take our eye off the ball. There's some data emerging on new evidence emerging on the fact that it's certainly in low income and middle income countries that disruption of health services for children and families is having an impact on their outcome. And we may be able to talk to Dr. Dan a little later about some of this. The other, and as a consequence, I suppose, of this recovery process, we're starting to see 2 things. We're starting to see our emergency department becoming busier. The second is our clinics are starting to really get into full flow. And lastly, elective surgery is coming into full flow. So we're close to 100% with our elective cases, and we know that we have a number of children whose operations were postponed, and we are planning hard to get those in. Now, that's not an inconsiderable number of children, but the team is really focused on it. The important thing, I suppose, that sits at the back of all this is that if we're to ensure that we maintain our services, we have to adhere to our basic infection control measures. And I just want to remind staff of 2 issues. I think the first is it's really critical that you stay at home when you're unwell, and that you don't feel guilty. I know that health professionals can be very stoical, and I think we've got to be careful that this actually has some implications in the present environment. The second is, I think, to pause and just reflect about whether or not you've had a break recently. So the classic response that comes back is, look, I can't go anywhere, I might as well carry on working. Working in an environment where there's a pandemic for which you are in a constant state of alertness for is actually quite tiring. And quite stressful. So can I just ask that you take a moment to reflect as to when you've had some leave and when you've last had a break, and really encourage you to take some time out. Most of us we're all in a state where we are going to be in a state of preparedness and high alert for probably a relatively protracted period of time, and it's not really sustainable to maintain that level of vigilance without a break. So can I just encourage that? Now, I just wanted to move on as a consequence, following that, just to look at it. We keep on talking about preparedness, but I'm really keen to hear from Dr. Dan as to whether the evidence that's emerging is helping us keep on top of... Sorry, I am still learning. This is only my third show, 2 hours and 5 minutes into radio presenting as a skill. So Beck's very kindly and ably guiding me through. We're going to turn to Dr. Dan just maybe to reflect on some of the latest science that's guiding our practice. Now, I'm going to bring in a new technical term. Apparently, before Dr. Dan's allowed to speak, we have to have something called a sting, which is a bit of music playing. So Dan, I'm going to bring you on, but apparently I've got to have a sting first. So DJ Houston, over to you.
Call now on 6456 5629 or 0436 595 600 to ask a question.
Dr. Dan, welcome.
Thanks, Aresh. Glad
How's
to
it
be
been the past 2 weeks?
It's been a really interesting, 2 weeks from the point of view of, the scientific literature. Particularly from a pediatric point of view, there's been a few papers come out about the, association with Kawasaki's, or what's now termed PIMS-TS, which is the Pediatric Multisystem Inflammatory Syndrome, temporally associated with SARS, if you can keep track of that.
Oh my goodness.
But essentially there's been a few studies come out about this particular condition, which was first recognised probably only a month and a half ago in the UK in a number of paediatric patients who became severely unwell.
And Dan, does the fact that it's associated with the COVID virus give it any specific clinical, a unique clinical presentation? Does it change the treatment, or is it that we're seeing a syndrome that's appearing and the causes are a multitude?
So I think a lot of this wasn't really clear when this started happening, and I think you're absolutely right. Initially, when doctors in the UK started to see patients presenting with, what looked similar to Kawasaki's disease, very unwell and needing to come to ICU, the question was, well, does this have anything to do with SARS, or could this be because patients who would otherwise come earlier with Kawasaki's disease are staying home because of the lockdown and presenting late, more acutely unwell? But really what these papers have shown us, and the largest one actually comes from the UK, published in The Lancet by Elizabeth Whittaker about a week ago, looking at around 60 patients from the UK, is that the majority of these patients have evidence of infection with SARS-CoV-2. So I think most of them actually have antibody evidence, which suggests that they've had SARS-CoV-2 infection or COVID, and then following that, they're developing this inflammatory syndrome. And I guess the other important thing that's come out with this paper is that, and a couple of other papers, that it's not quite exactly the same as Kawasaki. So I guess taking a step backwards, for those listeners who might not be as familiar, Kawasaki's is, a disease that we see not infrequently in pediatrics, and it's really characterized by high fevers, rash, swollen lymph nodes, and most importantly, inflammation of the heart vessels in about a quarter of patients. And we can give treatment to reduce that risk of inflammation of the heart vessels down to 5%. And really what drives this condition is inflammation, and inflammation involving the blood vessels. And I guess what they observed in these patients in the UK more recently, and this is what's come out in the paper, is that some of the features of Kawasaki's also are present in these children who have this PIMS-TS condition, but actually the majority of them don't appear to have the full criteria for Kawasaki's disease, and it's probably a slightly different syndrome. And I guess that's important because the differences are, probably the most important difference is that they are much sicker than children with Kawasaki syndrome. Up to about half of them end up in ICU, needing to go onto a ventilator or needing support with their blood pressure. And also the involvement in the heart is a lot more common. So when you do blood tests, it looks like there's inflammation of the heart muscle, and when they do ultrasounds of the heart really is inflamed, and this condition seems to really focus on the heart, as well as a generalized inflammation.
Dan, that's fantastic. Can I ask you, I suppose, just two questions from the opposite spectrums? The first is, as a parent, and many of our colleagues are parents, what does that mean? I mean, how would you pick it up? What's as a mum or a dad, help me out. What would I be looking for?
So I think it's a tricky one. I think these children are very unwell. So I guess they have high fever that persists for a number of days. They might be sort of pale. They might not be eating and drinking as usual. One major feature which seems to be present in at least half of these patients is that they have severe tummy pain and diarrhea and vomiting. So I think I guess what does this mean for a parent out in the community? Obviously at WA and in Australia we don't have a lot of, infection with COVID happening at the moment. But I think any child that looks like this, who either has Kawasaki's or features consistent with PIMS-TS, should really be presenting to emergency or to the local doctor if it's less severe, so that they can make the call and assessment can be done. So I think prolonged fever that's unexplained, I guess particularly with severe abdominal pain, pallor in a child who's lethargic, that's always a cause for concern, and PIMS-TS is one of many causes, I guess, that could cause a child present like that. Yeah.
So Dan, just before I go to the next question, I'm just going to remind listeners that they can ask you questions directly on 6456 5629, or they can text 0436 595 600. Just while we wait for some listeners to call in, my second question is, there was quite a lot of press around the use of steroids and the beneficial impact it seems to be having. I mean, is that something that's also being seen in children, or is it the data based just on adults? Because from what you described around inflammation, it would seem logical that it might have an impact on kids as well.
I think this is really interesting, Aresh. I think based on what we've seen with PIMS-TS, it seems like it's an inflammatory response, and it's really almost like the immune system going into overdrive in these children following SARS infection or SARS-CoV-2 infection. And we don't really understand why, but all the markers in their blood and everything that we do suggests that their immune system just takes off, probably triggered by the infection. What's really interesting is that there's a little bit of overlap with Kawasaki's and other inflammatory disorders in children, although it seems to be a different thing. But also, when we look at the adults who have severe COVID, it's not that they just get a bad chest infection and they end up on a ventilator. When you look at their blood tests and their results, there's also, I guess, uncontrolled inflammation, which seems to be driving these really sick adults to end up in ICU. So there are some similarities between those two groups. I guess what steroids do is they're, an age-old anti-inflammatory medication. I think the old adage goes that no patient should die without a trial of steroids. And where this data's come from is the UK, where they've done a remarkable job. I think researchers in Oxford University, in the midst of a pandemic, sort of started a really large trial. Over 150 hospitals in the NHS were involved, really looking at, well, we don't know what treatment is appropriate for this condition. This is a new condition. What do we think might work? And they tested a number of different possibilities. I guess with that knowledge in mind that inflammation was part of it, I guess there was some thought as to whether steroids as an anti-inflammatory agents might help some of the sicker patients. And that started sort of a couple of months ago. And with the numbers that they've had in the UK, they've been able to recruit several thousand patients into this trial. And in looking at this trial results so far, I guess they've been able to, come to a couple of important conclusions, and one of these is that the patients who got steroids compared with those patients who didn't get steroids seem to have less likelihood of dying, and that reduction sort of is around the magnitude of a third. So I think a third reduction in death rate is what they found. I guess importantly, this is just a press release at the moment. We don't have the full paper, but the results are definitely promising, and I guess it makes us think, well, maybe inflammation is a big part of why people, adults as well as these children with PIMS-TS, are getting sick with COVID.
That's fantastic. I know that you very kindly celebrated some of the researchers. I suppose I can't let that go without highlighting the researchers in this building. So there's quite a big piece in the West Australian today highlighting the COVID research that's going on in Western Australia that I think we should proudly shout from the rooftops about. And I suppose from within this building, we mustn't forget the important role that TKI plays in leading child research, and also our clinicians who work across there. So I must give Dr. Asha Bowen a shout for the work she's been doing together with Professor Chris Blythe. in the DETECT study, which is up and running. We were lucky to have Terry Browett from Community Health come and talk about the work they are doing to help support this important study. So we hope, I suppose, that WA is also at the forefront of informing the way forward around the management and understanding this disease as it affects children, as well as the work that's obviously going in the adult sphere.
Yeah, absolutely. And I think that's, although we haven't had a large number of cases in WA, I think there's been a lot of work that's gone in and collaboration, not only across the country, but also with our Trans-Tasman colleagues and further afield sort of internationally to really sort of, I guess, use the tools that we have here and the ability to do research to actually impact, I guess this pandemic, both for children, healthcare workers, and also sort of more broadly in adults as well. It's been fantastically impressive, yeah.
Well, Dan, I think there's someone else who's wanting to just benefit from your knowledge. Beck is taking a call.
I have a question for you, Dan. So we know that visitor screening has recently been introduced to all our sites. Why is it important to screen people once they come to our sites when there is no COVID in WA?
Yeah, so I think it's a great question, and really I think it comes back to what Aresh said in his introduction, that we're in a very good position at the moment, but what we want to avoid is complacency. And I guess as an example, you might have seen the news probably about 2 or 3 weeks ago from New Zealand, where they declared that they'd eliminated sort of COVID and really just relaxed down sort of restrictions and sort of said we've defeated it. The Prime Minister did a dance and sort of it was good news. But I think what they found just in this last week is that they've had a couple of cases which were missed in quarantine. So 2 travellers who returned from overseas who breached their quarantine and then sort of had about 300 contacts and then subsequently tested positive for SARS-CoV-2, and they've had to sort of do a massive trace to that, and things have sort of, I guess, escalated again in their country. Certainly they've got good capacity there, but I think it's really important to know that although we're in a good situation here in WA, what we know about this virus is that it can take off, and that's why I guess leading from the front we should be modelling to the community that we should remain vigilant, because we know that we don't want to lose the advantage that we've got at the moment and I guess slide back to a less ideal situation.
It's fantastic, Dan. I think we're having some technological problems, but I think we were close to having a second question, and there you are, Beck. It's yours again.
As PIMS-TS is different to Kawasaki's, if COVID-19 hadn't appeared, are these children likely to have developed Kawasaki's instead of PIMS-TS?
It's a great question, and I think a really, I guess, good point to speak on. Some of the interesting things we've seen with these children with PIMS-TS is that they seem to be older than the children who are Kawasaki's. So usually Kawasaki's is a disease of children under 5, and the average age for PIMS-TS seems to be about 10 years old. So I think they've probably gone past the stage where they would have developed Kawasaki's, because most of the kids who develop Kawasaki's will have it early on. So there may still be some predisposition in these kids to develop this inflammatory condition, maybe something about their immune system, which means that it's primed to take off when it encounters this particular virus. So far we don't understand so much about why. I guess we might be able to postulate from at least a couple of the larger studies, it seems that children from an African background who live in the UK or the US are overrepresented, so as opposed to Kawasaki's disease, where the highest prevalence rates are in Asia. And interestingly, and this is, I guess, from a very nice review that Dr. Matt O'Brien did for the COVID Journal Club just recently, he sort of pointed out that in Japan you've got high rates of Kawasaki's, but actually there haven't been reports from Hong Kong and China about children becoming unwell with PIMS-TS. So whether there's something about, I guess, genetic differences in immune system that predispose children, I guess, to PIMS-TS as opposed to predisposing them to Kawasaki's, I think so far there's some difference. I guess where we've been able to borrow from Kawasaki's disease is how to treat these children with PIMS-TS, because a lot of the features are similar, although there are differences. So for Kawasaki's, we tend to use anti-inflammatory medications, steroids sometimes, but also high-dose antibody or IVIG, intravenous immunoglobulin, and that's really what helps Kawasaki's children get better and prevents the damage to the heart vessels. And a lot of the children who've got PIMS-TS have received IVIG as well, and I guess aside from being very unwell, the reassuring thing for parents here is that although there have been sort of several hundred children now described in the literature with this, death appears to be pretty rare in that sort of when we give the treatment for Kawasaki's, whether it's because of the treatment or the actual sort of, I guess, condition and the natural history, these children tend to sort of get better, at least based on the evidence that we've got so far, which is promising. But probably they're different from the children who would have got Kawasaki's if it weren't for SARS-CoV-2.
That's fantastic, Dr. Dan. I mean, for those of you who can't see Dr. Dan, the reason I'm in awe is that actually he talks right through all the evidence without a single sheet of paper. So thanks very much for the tremendous amount of revision you're doing, and you have passed with flying colours today, Dr. Dan. Thank you very much. That's been fantastic, hugely informative. I don't know if you have time to stick around just in case there are some other questions, but if not, thank you. You've been tremendous again.
Happy to stick around. Thanks, Aresh.
That's fantastic.
Welcome to Radio CAHS, presented by CAHS Chief Executive Dr. Aresh Anwar.
Welcome to Radio
Well, Frank, thanks very much. I'm really privileged today to be joined by Frank Walsh, who works in the Aboriginal mental health space for CAMHS, the Child and Adolescent Mental Health Service. Frank, I know you're firstly, welcome.
Thank you.
The second thing is I'm feeling mildly anxious because Beck warned me that you were an old hand at radio.
A long time ago.
A long time. You never lose the art.
No,
So, Frank, firstly, thank you for giving up your afternoon. I just wondered whether you would just run through a bit of your background for both myself and the listeners today.
Okay. Well, I'm Buddy Meyer Nunda man, originally from Mount Magnet. So my mum's family are from the coast, around Northampton. My dad comes from inland, around the Mount Magnet area in the Midwest, Murchison, and we've also got ties to Wadjuri and also up to Kidgib people that we've since found out through the Stolen Generation. So that's basically me and some of the background from my family. So got 8 brothers and sisters.
Right.
So there are 8 of us, so it's a fairly big family.
Big family.
Yeah. And I was raised primarily the first 6-7 years out on a sheep station or a pastoral station just to the north of town. And then we eventually moved into town and began our journey, I suppose.
And how long have you been in Perth for?
On and off, I reckon the best part of the past 30-odd years.
And I described you as a health professional working in the mental health space. I mean, have you always been in that space, or...?
No, I've had varied roles throughout my journey. It's only fairly recently that I've really got into the mental health space. So I basically work for Warwick CAMHS.
Right.
I've been there now coming up to, I'm in my 2nd year, so November will be 2 years for me. There are 6 Aboriginal workers in the in that particular program. Warlangnyet Werin Murich, I think that's the name. It's a Noongar word.
Yes.
That's the name of our program, and I think it's been going for about 6 years now.
And what are the I suppose the main challenges that you're seeing that our Aboriginal children are facing? What are the challenges that are present to you on an average day? I mean, could you run through a day for us?
Well, mental health for Aboriginal people in particular, and
Yes.
also for our kids, is such a big need for services out there to get our kids into accessing services and culturally appropriate services. Obviously, that's really important. A lot of the problems we're seeing are intergenerational because of the stolen generation.
Yes.
So the impact of a lot of the issues currently going on in our communities and within our Aboriginal society has come directly from, I suppose, the impact of all colonisation and also being a stolen generation. We're seeing families now who maybe 3 or 4 generations into when their grandfathers or great-grandfathers were actually removed.
Right.
And so that impact upon them now has been, it's highly visible in our communities.
And what are the sort of are you seeing people in a sort of traditional clinic setting, or actually is the Aboriginal mental health team much more embedded in the community?
I think now the Aboriginal mental health, particularly within our space, and I know we met this morning and with our team, Aresh, I think there's great work going on behind the scenes around a whole heap of things, and in particular the cultural security review that's currently going on within CAMHS. So there's a whole heap of work being done around that space. It's important that I suppose there was a big discussion around cultural safety.
There was. I mean, I suppose I left. It was a very, very frank. I would call it a frank and fearless discussion around. I suppose there was a very biological element to it, where we were really warned about the potential to make a misdiagnosis if the cultural elements which help support a child and family are ignored. I think that came across very strongly, that you just can't ignore that because it has really significant long-term implications. And then we talked about ensuring the framework for our patients, our children, our families and our staff was absolutely safe in order to allow access interaction to occur in a free manner. And
that will all be part and parcel, I guess, of the cultural security review that's happening now across the board. We're lucky to have the chairman of or the chairperson of CAHS, obviously, there with us. So the message we're trying to get out is it's really important that the Aboriginal space is actually supported.
Yes.
Aboriginal clients are supported, and we need to be working in a culturally appropriate space, and also identifying what's our best practice as Aboriginal workers working in this mental health space. So that's really important. Far too long we've had, there are too many stories of neglect, I suppose, from Aboriginal clients accessing services, accessing the health services right across the board, and certainly, you know, in the state. There are many issues, of course, with Aboriginal space in general. The Black Lives Matter is a really good example of that, and the deaths in custody. I mean, that's a really topical conversation that's happening right now. We've seen those discussions happening right around, not just here in WA, but certainly around the world. So a lot of those conversations are really topical, and I think Aboriginal people look at what's going on and what happened in America, and there are very much similarities between a lot of that stuff that goes on over there, and we compare that to the way Aboriginal society is here.
I know that one of the challenges that you threw out this morning, Frank, and as did the rest of the team, was that we read about this, and we talked about the review to try and get a really robust framework and understanding of where we find ourselves. But the second thing was there were some simple steps that we can take here and now, and that each of us needs to pause and just reflect on our behaviours and the actions that we can do to really make sure that actually we ourselves embody a challenge to racism and to discrimination, and that it doesn't necessarily require a review for that stark reality to be driven home.
Yeah, I think so. And look, having a look at the protests that have happened around the world, and even here in Australia, there are a lot of Wadjula people or non-Aboriginal people that are actually participating in those protests.
Absolutely.
As well. You know, a lot of dark-skinned people. So not just Aboriginal people, but a lot of other cultures, you know, are getting out there on the street and having a say, basically, putting up their hands and saying enough is enough. unfortunately for Australia, we live in a society that there has been and such systemic racism in this country for a long time, and until people get together and harness the goodness of really good people and coming together and trying to look at ways of making things right, basically. I think that's what needs to happen. I think also in the health space, in the mental health space, that we do, until we get really good people coming on board, all working together, the cultural security review, I know that's a good thing, and we've got some really good Wadula colleagues who are supporting that process and working alongside that process. Even my own office out at Warwick, and a shout out to the guys over there at Warwick. I know I think
they'll
are
be
listening.
listening.
Yeah, so Mark and Chris and a few others. So we've got a really good team, and you know what? For us, it's a two-way thing. So we have to continually be educating Wadulars and non-Aboriginal people about the Aboriginal space, and it's a two-way learning thing for us.
I mean, it's interesting because that's the other. I mean, we can't keep on reflecting on the conversation we had this morning, but I know the other really high point of this morning was just the moment to pause and reflect and celebrate some of the good stuff that's going on.
Yes.
So certainly your team, an embodiment of work to celebrate. I know that we have the Aboriginal Health team that works in the community health space, and also Colini Mort that's also helping support vulnerable children and families. But the challenge was, how do you work closer together to make sure that actually we're not talking about separate services, but that the child and family are at the centre, and that we pull together?
Yeah, well, it's interesting. Dr. Helen Milleroy is part of our team as well. I know we spoke about that this morning, and she said, look, the whole idea of holistic services actually came from Aboriginal people a long time ago. And so she's been around for many, many years.
I'm not sure she'd say thank you when you say that.
No, but certainly she has. And just talking about that. And so the whole concept and notion of the way we work as Aboriginal people.
Yes.
It is a holistic approach to the way we deliver our services. And it's important for our colleagues, and particularly our Wadula colleagues, to embrace the way we work. And it's about keep educating our Wadula colleagues, even our managers, and all the way up to sort of internally within the organisational structures of any organisation, so whether it be health, whether it be some other industry, but that's the way Aboriginal people like to work. And I know it's kind of exciting working in this space, and it kind of feels good to be able to do that, particularly working with the children and their families. And it's really encouraging for those families when they do get their referral and come into a service, they see an Aboriginal face. They see a black face.
Well, we know that increases rate of access and referrals. I want to also just celebrate that Professor Helen Milroy is part of the team. I mean, she is an absolutely outstanding, eminent academic who's helping support this work. So, which is really a really important thing to celebrate as part of our service, that we have world-leading clinicians helping provide care and support for the children who access the service. I just wondered, Frank, you said that you'd been in CAMHS coming up to 2 years, I think you said in November. But do you have a background in the arts before you came to health?
I do. And community management. So prior to CAMHS, I worked in the Wheatbelt in adult mental health services, so which again, obviously a big need for services for our Aboriginal families as well. There's a saying amongst us, myself and my colleagues, our work doesn't stop at 5 o'clock when we go home.
Because
our work actually continues 24/7. And I know one of the colleagues in particular, I know she's a strong advocate of educating people about that fact. We just don't close the door at 5 o'clock. Quite often you'll get family members or other extended family people who may put a phone call into you at all hours of the night. You know, over the weekend you'll see run into families or other people, friends, for example, who want to seek advice on how to access mental health services. And, you know, we're not going to say no as Aboriginal people, because that's not the way we work. Quite often we'll try and direct them in the right place. And that's a reality of the work that we do. So, you know, we're out there all the time doing the role.
Well, I'm always worried about naming individuals, because that always means if you name one, you forget another. But maybe this is a good point to bring in. I just want to reflect, for example, the work that Josie's been doing in Armidale, in trying to raise community knowledge of the services that are out there to help support individuals, which I think probably reflects what you're just telling me about, that this is actually being part of the community is as much part of the job as the professional title you hold and the families you see through a formal referral process.
Well, Josie's fantastic for people who don't know, but Josie's one of the colleagues. And she does a terrific work down in the Armidale area. I've got other colleagues spread around the metropolitan area. We all do a fantastic job, I believe. And
you do a fantastic job, absolutely. And all colleagues do. You're absolutely right. I said I was worried about naming one. Josie's an absolute superstar, but the entire team's incredible.
So, look, quite exciting times, I think, for our Aboriginal space within our SAMHS team. You know, particularly now with, I think, the director's role, Director of Aboriginal Health now will be coming on board or will be appointed soon.
We've got an interview coming up, I think, shortly.
As will our new coordinator of this position. And these roles have actually taken a long time, particularly the coordinator's positions. But these roles are very important to the future direction of how our team works and what direction we will actually go down.
Frank, look, you've been very generous with your time. You've been very generous with your commentary, and you've been generous in celebrating that a director of Aboriginal Health and a coordinator is coming. But I suppose what I just want to make sure is that that I acknowledge that's simply not enough, and there's actually a lot of work for the organisation to do to ensure that we meet our obligations, to ensure that the Aboriginal children actually have the very, very best chance of flourishing, and our staff equally have the very best chance of flourishing. So this is just the beginning.
Sure.
So, Frank, thanks ever so much. I think I've got to go into a sting to give people the opportunity to ask us some questions. Frank, thanks ever so much.
Yeah, thank you, Aresh.
Call now on 6456 5629 or 0436 595 600 to ask a question.
So, Beck, this is a slightly scary bit where we're waiting for some questions, and I just wondered whether there's anything that had come through.
I do have one. Can you please speak about returning to normal clinic-based appointments for clinicians at the Child Development Service?
Okay. So I think where possible, we are trying to return to face-to-face appointments. I mean, there are places where that's just not been possible. We've got a really important issue, which is to ensure that we adhere to infection control measures. So where we can't maintain social distancing, then face-to-face appointments sadly can't kick in yet. So an example of that actually is somewhere we've been talking about earlier is Armidale. So we apologise to all those children and family where we continue to interact digitally. So care is being provided, but face-to-face at the moment is being moderated by our ability to adhere to infection control measures.
Great, thank you. Another question we have is, have you got an update for what is happening in the health and well-being space at CAHS?
Do you know what? I'm super excited. So just because it's only 2 weeks since we started the show, people will remember that Valerie Jovanovic, our new Exec Director for People, Culture and Capability, came to speak about some of her vision around how we should lead and ensure that we support staff. So I think there are two big bits of news. The first is that on Monday we have a new health and wellness coordinator starting. So we'll say hello to her in her absence, and that's Evelyn. So I think she'll have an enormous impact. especially when we reflect on the significant amount of stress that's around at the moment in relation to COVID and COVID preparedness. And I think the second is we're currently reviewing how we support staff better after clinical incidents. We know, again, just the sense of ownership that everyone has and the amount of reflection that goes in, and we know that we've got to improve the way we support staff. So I'll provide an update on, I think, in the next couple of weeks.
And I have one more from the text. This is from Amanda Wilkins. Can you talk about CAHS' response to the coroner's report on the suicide deaths of children in the Kimberley and the probable link to FASD and prenatal alcohol exposure in the context of historical trauma?
Yeah. Oh my goodness, that's a big topic, and it's great that Frank's here. I think the first is, can I go back to the beginning of the show and the acknowledgement to country? I think the important thing is to remember that when we acknowledge country and pay our respects, that we know that those words come with a sense of responsibility around what our role in CAHS is to make sure that we address inequity. So I think the report around the suicide in children and young people in the Kimberley, which was published about a year ago, really actually looked at what I suppose I would describe as some of the structural inequalities that exist. So it was around poverty, it's around housing, it's around access to care, and Frank has touched around access to mental health support. One element of it was undoubtedly alcohol. But the answer is not a simple one. It's about us as a society pulling together and addressing a range of issues. So CAMHS, I think, is working in collaboration with WACS to try and address some of the gaps where we are absolutely empowered to do that. So, of course, the diagnosis of FASD is an important element for that, but it's not the only thing, and we've got to just make sure that in order to reduce suicide, we've got to address a far broader set of issues. Frank, do you want to add anything to that?
I'd just like to highlight the fact that, yes, there have been a lot of suicides in the Kimberley, but there are also, just for people out there, there are a lot of suicides in many other regions around the state as well. So it's a well-known fact within our communities of the amount of suicides that occur in various regions of the state, and yeah, it's quite tragic for a lot of those families, but that's a reality that we live in within our Aboriginal space.
I think, Frank, you're right. I think it's a harrowing reality, and I think it's really got to be a really important piece of how we develop our services going forward to make sure that we absolutely make every contribution we can to minimising the impact of that and reducing the number of suicides that occur, because every one is unacceptable and tragic. Right, now I've been told that that's a wrap. So I have got a question that DJ Houston put to put last night in her show to Monica CAHS. Now I have warned our guests today about this. So Frank, I think you're lucky, because I normally ask our guests what their favourite biscuit is. Now I am not going to pass by. Do you want to comment on your favourite biscuit, or are you going to give a pass on that one?
I like it shortbread.
Shortbread. Okay, well, thank you very much for a rapid response there. Now, I'm going to put this to you and Dan. So I understood that the debate that was, DJ Houston, am I right? You created a bit of a hoo-ha because you asked Monica CAHS as to whether pineapples belong to a pizza.
Yes.
Oh, my goodness. So, Frank, pineapples belonging to a pizza, yes or no?
I'm a supreme pizza eater. So
you're a supreme eater?
Worry me. I chose not to eat Hawaiian or pineapple.
Okay, you're quite particular. Yeah. But with that, I take it that pineapples don't belong on pizzas. This is the most challenging question I posed to you, I know. You've discussed world politics, but this one...
I love pineapple, so I'd say yes.
Oh, okay. Okay, now, Dr. Dan, you've talked about Kawasaki without any notes. You've reviewed world literature. What is your view on pineapple on pizza?
I think in our house, with sort of 3 young boys, 2 of whom join us for takeaway pizza, I think definite yes for pineapple on pizza.
Okay, well, that's a question I'm going to have to leave the organisation with. I hope it doesn't send us into meltdown, DJ Houston. Can I once again thank Radio Lollipop for the tremendous support that they've given us. Can I ask if you could carry on giving us as many questions as you can, because that gives us at least some prep time, and Beck doesn't have to run around the studio trying to strangle me because I'm deviating off the path and the sheet she's given me, and we will put this out on a podcast. But thank you very much for all the work that you do each and every day. I thank Frank Walsh for giving up time today and really having a very frank discussion with us. I thank Dr. Dan for all the work that he does to make sure that we are kept up to date, and I thank you for all the work that you do in keeping children safe. So take care and have a lovely weekend.
Welcome to Radio CAHS, presented by CAHS Chief Executive Dr. Aresh Anwar.